Hello, and welcome to the Wellness Pharmacist. I'm Dr. Kat, your host, and today we're exploring a condition called Drug-Induced Lupus erythematosus, or DILE. This topic is relevant for both healthcare professionals and people prescribed this medication, these medications that cause it, because it's critical to understanding how some treatments can have unintended effects. Drug-induced lupus erythematosus is a form of lupus that occurs due to taking certain medications. We'll cover its prevalence, types of medications most likely to cause it, and of course the best ways to manage and resolve symptoms. As a disclaimer, this episode is for educational and informational purposes only. Always seek the advice of your own healthcare team. So for today's discussion, I've referenced sources from reputable organizations like the Mayo Clinic, Johns Hopkins Medicine, and Rheumatology Advisor. What is drug-induced lupus erythematosus? So DILE is an autoimmune condition that mirrors symptoms of lupus. So this is where the body's immune system mistakenly identifies its own tissues as foreign and then attacks it. However, unlike idiopathic lupus, drug-induced lupus is directly associated with the use of certain medications that are prescribed and tends to resolve once the offending drug is discontinued. So what are the characteristics? The onset of these manifestations typically occur after several months of continuous exposure to particular medication. So we're looking generally at 3 to 6 months after you start a medication that's known to cause drug-induced lupus. It normally arises within 3 to 6 months. However, there are cases where it can appear 2 to 3 years after starting the medication. So it's important to remember that. Normally, it's within 3 to 6 months of continuous use. Symptoms: most people with drug-induced lupus experience joint pain, muscle pain, and fatigue. We have diffuse skin rashes, including the malar rash on the face that you would normally see in systemic lupus, idiopathic lupus, which is that butterfly rash over the bridge of the nose and on the cheeks. And then, of course, you have flu-like symptoms. We can have alopecia, pleuritis, those sorts of things. The flu-like symptoms, the skin rashes, the joint pain, muscle pain, fatigue, and alopecia, these are common. Some of the other things are not as common, but we'll go over those too. Then we have antibodies. Unlike systemic lupus, the drug-induced lupus form generally lacks some of the more severe organ involvement, thankfully, although sometimes it can occur. However, people often test positive for anti-nuclear antibodies, the ANA, and antihistone antibodies. This helps in kind of differentiating drug-induced versus idiopathic or systemic lupus, although it is tricky. Prevalence: drug-induced lupus is relatively rare compared to systemic lupus, and while any person taking a causative medication may potentially develop it, overall the risk remains low. However, I do have to say that there are over 100 medications identified now that can cause drug-induced lupus. That's a lot. So we have to be vigilant and remain vigilant as healthcare providers and, of course, as people taking these medications. The exact prevalence is difficult to estimate because each medication has its own risk profile for causing drug-induced lupus, but research suggests that for some medications like hydralazine, up to 5 to 8% of people may develop drug-induced lupus symptoms. However, this often occurs more in men than in women, which is a huge difference because normally systemic lupus occurs in women of childbearing years, and it can occur later on, but it's generally seen in young women and up to the age of 45. But this occurs more often in men than women because they take more of the offending medications. They're prescribed more of the medications that trigger it. So we have some genetic factors that may predispose a person to drug-induced lupus. And I'll go into those in more detail in just a minute. The drugs associated with drug-induced lupus are classified as a definite association, a probable association, a possible association, or recently reported. There's another way to classify them, which is high, medium, low, or very low risk. So again, as you can see with hydralazine, 5 to 8% may develop it, but there's like procainamide can be up to 20%. For more background information, you can always read Mayo Clinic's overview on lupus and explore Johns Hopkins resources on drug-induced lupus. There's also something on it with the Lupus Foundation of America and Rheumatology Advisor. Okay, so medications that cause drug-induced lupus. As I said, currently there's over 100 medications that have been identified as potential triggers for it. The mechanism behind it is not entirely understood, just like lupus is not entirely understood, but it's believed that certain medications can modify the immune system, leading the body to produce antibodies against its own healthy tissues. Some drugs have a higher likelihood of causing DILE than others. The most common offenders: hydralazine, procainamide, isoniazid, and quinidine. Those are the most common. So hydralazine, it's often used to treat high blood pressure. It's one of the drugs most associated with it. It's estimated that between 5 to 8% of people on it may develop drug-induced lupus over time. Then we have procainamide. This is an antiarrhythmic medication used for irregular heart rhythms. The prevalence of drug-induced lupus with procainamide, as I just mentioned, it can affect up to 20% of long-term users, particularly those, though, with high doses of procainamide. 3, we have isoniazid. This is prescribed to treat tuberculosis. Isoniazid is another well-known drug-induced lupus trigger. While its risk is lower than hydralazine or procainamide, long-term users should be monitored for the symptoms. We also have TNF inhibitors like infliximab, adalimumab. TNF inhibitors, and these are actually taken in autoimmune conditions, and so this can be very difficult because if you already have like systemic lupus and you're taking one of these things, and then you have this on top of it, it can be extremely difficult to determine, is it the medication or is it the underlying actual lupus that you have. So this is where it gets tricky. TNF inhibitors are used to manage autoimmune diseases, like I said, like rheumatoid arthritis, and can also lead to lupus-like syndrome. These drugs may modify immune regulation in ways that then obviously trigger drug-induced lupus erythematosus symptoms, although they're typically reversible upon stopping the medication. We have other drugs too, like minocycline, which is for acne, methyldopa for hypertension, and certain anti-seizure drugs like carbamazepine, phenytoin, valproic acid, ethosuximide, trimethadone, primidone, and zonisamide. Those are anti-seizure medications. So not all anti-seizure medications do it, but as you can see, there's a lot. They've been implicated in drug-induced lupus cases. However, they're less common, but there's enough of them out there reported that I have to make a note of it. So again, hydralazine, procainamide, isoniazid, and quinidine are the most common culprits. For more detailed information on drugs associated with drug-induced lupus, check out the Lupus Foundation's list of medications linked to it. Mechanism and development of drug-induced lupus. So again, we don't know the exact reason why. It's not fully understood, but there are some theories. One is immune system dysregulation. Certain medications appear to alter the immune function, and this would then increase autoantibody production like anti-nuclear antibodies and single-strand DNA. This then programs the body to attack its own healthy cells. We have a genetic susceptibility, though. I mentioned that before. So not everyone who takes these medications will develop drug-induced lupus. There is a genetic predisposition, though, that plays a role, as certain individuals have immune systems more susceptible to drug-induced changes, like having certain human leukocyte antigens, which we call HLA. For healthcare professionals out there, you'll recognize that. And so we need to be aware of that for HLA-DR2, HLA-DR3, class 3 C4a, and C4b null complement alleles. These can all increase someone's chances of having drug-induced lupus. And I want to remind people out there that we have something called pharmacogenomics, and it's a burgeoning field. We are getting better at it all the time, and including more drug classes into it, because since it's in its baby steps, infancy stage, we don't have all the medications out there genetically profiled. However, we're getting better all the time, and this is something that could really help. And so we would test your blood. For people listening, we would just have a nice lab test as usual, and then we can check for your genetics and see which medications your body prefers, and which are medications that you could have serious complications from. So pharmacogenomics is really exciting, and I advise you to talk to your physicians about it, but especially your pharmacists, because your pharmacists are extremely knowledgeable in this. So if you have any questions about that or want me to do an episode on that, please let me know, and I can do an episode on what pharmacogenomics really is. We also have slow acetylators that can have an issue that can trigger drug-induced lupus. What's a slow acetylator? Excuse me. It's just a person that has a liver that breaks down medications more slowly. So again, we have certain tissue types like HLA DR4, DR2, DR3, DR0301, DQB1, B8, and of course I said the complement C4 null alleles, which is a complement protein needed for blood clotting. As you can see, we're getting better and better at figuring out who reacts to what. The drugs associated with drug-induced lupus are classified again as definite association, probable association, possible association, or recently reported, and again can be high, medium, low, or very low risk. I just want to repeat that. We have oxidative stress and inflammatory response that could trigger it. Some medicines may trigger inflammation or oxidative stress, and this obviously leads to an immune response that mimics lupus. With drug-induced lupus erythematosus, anti-nuclear antibodies tend to be positive, and we can have more antihistone antibodies present than they would be for idiopathic lupus, although they can still be there. Anti-double-stranded DNA and extractable nuclear antigen are rarely positive, though, when you have drug-induced lupus. So if you don't have anti-double-stranded DNA and you don't have extractable nuclear antigen, ENA, chances are it's drug-induced. We can have an elevation in erythrocyte sedimentation rate, ESR, though, in drug-induced. So in the cutaneous form, though, we rarely see antihistones present. So when we have just skin manifestations, we rarely have antihistones present, but we do have a positive anti-nuclear antibody, ANA. But again, even with the cutaneous form of drug-induced lupus, they are negative for the ENA, extractable nuclear antigen, and the double-stranded DNA. Resources for further reading: Johns Hopkins Medicine article on lupus, Medline Plus for autoimmune responses, and of course, Rheumatology Advisor. Okay, what's the diagnosis for drug-induced lupus, and what, again, let me review the symptoms. Diagnosis involves a combination of a person's history, symptom assessment, and of course laboratory testing. The key symptoms we're looking for here are joint pain and stiffness. We often see it on both sides, so they're symmetrical. So if we have pain in the right knee, we expect it in the left knee. And it involves multiple joints though. Fatigue, it's very similar to systemic lupus. We have patients experiencing extreme fatigue. Muscle pain is a common symptom, although it's obviously less specific to drug-induced lupus. And rashes, we can have diffuse rashes all over the body, and then the malar rash on the face, the butterfly rash that we can see. Lab testing, we clearly want to do anti-nuclear antibodies, ANA. Again, most test positive for it. Antihistone antibodies, these are present in a large majority of people with drug-induced lupus, and it can help differentiate it from systemic lupus Certain lab tests, other lab tests that we want to do are ANCA panels, which is anti-neutrophil cytoplasmic antibody, complete blood cell count with differential, so CBC with diff, comprehensive chemistry panel, a urinalysis, so be in a cup for people listening, a chest x-ray, because that can show signs if there's pleuritis or pericarditis involved, an ECG, because that can show if the heart is affected as well, skin exam, obviously if you're having skin rashes and stuff, we have to look at it. As a general rule, a diagnosis of drug-induced lupus requires at least one symptom of systemic lupus. We have to have a positive ANA, anti-nuclear antibody, and then, of course, the other lupus blood work. So in addition to a detailed symptom history, labs are critical. They're vital. If symptoms arise during a new medication regime or regimen, consider drug-induced lupus, and then consult with, if you're a person taking this medication, consult with your healthcare provider that prescribed it. Resolving it. So we have it. How do we resolve it? How do we manage it? Fortunately, with drug-induced lupus, it's usually reversible. Sometimes not, but usually it is. First off, we want to discontinue the triggering medication. That's obvious. So the primary approach is to stop the triggering medication. Symptoms generally start to subside within weeks to months after discontinuing the medication. In the meantime, we want symptom management. So that includes non-steroidal anti-inflammatory drugs, NSAIDs, that are often prescribed or you can get over the counter if it's a mild form of it, to help manage joint pain and inflammation. And in some cases, there's a call for a short course of corticosteroids like prednisone may be used for symptom relief. Azathioprine and methotrexate might be necessary if it's more moderate to severe symptoms. And in the case that all other treatments have failed, then we turn to cyclophosphamide. We do want to monitor, so as healthcare providers that I'm talking to right here, we want to monitor for drug-induced lupus in our patients and our clients that are on the known trigger medications, which are again hydralazine, procainamide, isoniazid, and quinidine. These are the most common culprits. So consider periodic anti-nuclear antibody tests for those on higher risk medications. If you have them sitting down and you're on a medication for blood pressure, or because we're talking oral antifungal medications and ACE inhibitors and stuff. So if we're prescribing, medications for people and they're on these medications, it always, if they're sitting down for routine blood work, just add on the ANA and see, because the sooner we can get to this, the better for our patients. So just consider taking periodic ANA tests for those. Patient education, extremely important. Everyone that's taking a trigger medication, it's important to inform them about the potential signs of drug-induced lupus. Obviously, this is so that they can catch it early. And if I'm talking to you, if you're taking a medication and you're hearing this and hey, I'm taking this medication, just being more aware of what it is that you're taking and the side effects. That's obviously critical for your health and well-being and longevity. So if you notice any signs or symptoms, please talk to your healthcare provider that prescribed it, because the earlier we can get to it, the better off you are. The main symptoms are, again, muscle and joint pain and swelling, alopecia, so hair loss, that is one, pleuritis, pericarditis, so inflammation around the heart in the pleural cavity, flu-like manifestations. So if you feel like you're getting the flu, and that's hard, especially this time of year because flu is around, but just consider that. Malar rash, which is that butterfly rash on the face, and you can have diffuse rashes all over the body too. And then other cutaneous symptoms, other skin. Photosensitivity is one. So if you go outside and you get sunburned and you're like, whoa, that was fast. Purpura, erythema nodosum for the healthcare professionals, vasculitis, inflammation of the veins, mouth ulcers, oral ulcers, and discoid lesions. For more on the management, please see Medline Plus guidelines and rheumatology advisor on managing drug-induced lupus. So I know that was a lot. But I want to thank you for staying with me and joining me today for this important episode on drug-induced lupus erythematosus, because if you or someone you know is on an offending or triggering medication and starts experiencing symptoms like the joint pain, the fatigue, the hair loss, the skin changes, please reach out to your healthcare provider. The sooner the better, because awareness is essential for both the healthcare professionals and, of course, people taking the medication to then recognize and to manage this condition effectively. So stay tuned for more in-depth discussions on autoimmune-related topics and chronic illness. And until next time, stay well.